This is Randy Schell, and I'm making a podcast entitled Cardiovascular Pharmacology Keyword-Based Review. This is part of the University of Kentucky College of Medicine Department of Anesthesiology educational series. There's some suggested reading that I have here, including Clinical Anesthesia Fundamentals by Dr. Barish, published in 2015, as well as Stolting's Physiology and Pharmacology, 5th edition, 2015, page 449 through 532. This review will be guided by the American Board of Anesthesia Keywords, published between 2010 and 2016, and those can be broken down into several large categories, including inotropes, milrinone and its inodilating effect, vasopressors focusing on vasopressin, vasodilators, Nitroprusside, nitroglycerin, and nitric oxide, ACE and ARBs, that is angiotensin converting enzyme inhibitors, beta blockers, and antiarrhythmics, specifically amiodarone. So let's move right into our discussion, starting off with inotropes. And look at the graphic to the far right. You can see that the mechanism of action of inotropes is shown. First of all, the beta receptor, which can be activated by drugs like dopamine, dobutamine, epinephrine, and norepinephrine. When it is activated, cyclic AMP is increased via communication via G protein. That cyclic AMP results in increased intracellular calcium and the effects of beta receptor agonism, including increased contractility, heart rate, etc. In the top right shows the action of Digitoxin, which is sodium-potassium ATPase inhibition. And you can see here that the sodium-potassium ATPase is normally pumping potassium in and sodium out. If that ATPase is inhibited, sodium builds up in the inside of the cell, and the sodium-calcium coupler will not work as well. Calcium then stays inside the cell and has its effect. So intracellular calcium increases is associated with the effect of digoxin, digitalis, as well as the beta receptor agonists. If you look at milrinone, milrinone acts via inhibition of phosphodiesterase type 3, an enzyme that breaks down cyclic AMP to inactive AMP. So you can see now that if you have beta receptor agonism, for example, with epinephrine, and add milrinone to it, not only do you have increased production of cyclic AMP, but also decreased breakdown of cyclic AMP and synergistic action. So if we summarize the mechanisms of actions at the top left, you can see digitalis is the sodium-potassium ATPase inhibition. Epinephrine has alpha-1 effects, vasoconstriction, beta-1 effects, increased contractility, for example, and beta-2 effects, vasodilation. Dobutamine has beta-1 and beta-2 effects, while isoproterenol also has beta-1 and beta-2 effects, and dopamine has a mix depending upon the dosing. Dopamine 1 receptor, beta-1 receptor, and alpha-1 receptor. Catecholamines tend to have a rapid offset, and the main reason is that they are metabolized by an enzyme called catechol-O-methyltransferase. For example, during CPR, when you're administering epinephrine, you administer every 3 to 5 minutes or so. So relatively fast offset of catecholamines. Let's look now at beta agonist effect and separate it into beta 1 and beta 2. When you have beta agonism, you can see that cyclic AMP increases, and if you follow it down to the left, you find that cytosolic calcium goes up, resulting in increased inotropy and increased chronotropy. Beta agonism also, via different pathway, results in augmented calcium uptake by the sarcoplasmic reticulum and vascular smooth muscle, resulting in vasodilation. So beta 2 effects, vasodilation, beta 1 effects, chronotropy, increased heart rate, and inotropy or contractility. Let's look at digitalis. Digitalis is a cardiac glycoside, as previously mentioned, inhibits sodium-potassium ATPase in the cardiac myocyte, which then increases available intracellular calcium. In the past, it was used for atrial fibrillation in patients where you're attempting to control the ventricular rate. This is not used very often. We have drugs like amiodarone, diltiazem, beta blockers like esmol and metoprolol that are more frequently used. And it's rarely used anymore for its, quotes, inotropic effect. However, a DIG is occasionally still used and has a low therapeutic index and is associated with toxicity, and we need to know how to treat that. The diagnosis of digitoxin or digoxin toxicity is often associated with cardiac arrhythmias. For example, sinus bradycardia, conduction delays, heart block, bad ventricular dysrhythmias. One of the first things that you should do when you suspect digoxin toxicity, i.e. EKG changes and dysrhythmias, look at your potassium level and make sure that you fix hypokalemia. There are DIG binding antibodies that can be utilized, magnesium administered, as well as phenytoin to treat digoxin toxicity. Epinephrine has beta 1 and beta 2 effects as well as alpha 1 agonistic effects. At relatively low doses it tends to be beta, and at higher doses vasoconstriction or alpha. The uses of epinephrine, one is anaphylaxis. During anaphylaxis, the alpha 1 effect of epinephrine causes vasoconstriction, increasing the mean arterial pressure, which tends to be down, and decreasing mucosal edema, which mucosal edema tends to be increasing. So the alpha 1 effect is beneficial, but the beta 2 effect is also beneficial because it results in bronchodilation. Anaphylactic patients are often wheezing, and very importantly, the beta 2 effect results in stabilization of mast cells, so they stop releasing all the junk that's causing the anaphylactic response. During cardiac arrest, epinephrine is indicated at a dose of 1 milligram repeated every 3 to 5 minutes. The vasoconstriction that it causes improves organal blood flow during chest compressions. An important caveat is that when you have local anesthetic toxicity or LAS syndrome and you're using epinephrine, it's recommended that you decrease the dose to less than 1 mic per kilo per individual dose. In patients who have had a heart transplant, the vagus nerve has been cut as well as the sympathetic nerves T1 through T4, so it's called a denervated heart. If that heart becomes bradycardic, remember that it still has beta receptors present on the muscle, in fact can be upregulated and will respond to beta agonism. So in a patient who has had a heart transplant and is bradycardic and hypotensive, both, epinephrine would be indicated, because not only would it increase the heart rate, but the alpha effects would result in vasoconstriction, correcting both the bradycardia and the hypotension. Epinephrine is also used for bronchodilation in asthmatic patients and added to local anesthetics in an attempt to prolong the action by vasoconstriction. Some side effects of epinephrine include hyperglycemia, drives potassium into the cell, so hypokalemia, and ventricular dysrhythmias. Let's compare epinephrine to dobutamine now. Epinephrine had beta 1 and beta 2 effects like dobutamine, but epinephrine also had alpha 1 effects. Dobutamine is beta 1, beta 2, and is a synthetic catecholamine. Via the beta 1 receptor, contractility will go up, and via the beta 2 receptor, systemic vascular resistance will go down because of vasodilation. So dobutamine is often termed an ino, because of the increased inotropy, dilator because it decreases the vasculature resistance. Starting dobutamine can result in significant tachycardia via beta 1 agonism. Dobutamine is often used during a stress echocardiography where a patient is imaged and then a dobutamine infusion is started. As the dobutamine infusion goes up in increasing dosages, it increases myocardial oxygen demands and may result in myocardial ischemia, as evidenced by regional wall motion abnormalities such as severe hypokinesis or akinesis. Dobutamine used to be used in patients with congestive heart failure, but it's been linked to increased morbidity and mortality and therefore no longer recommended for chronic use of CHF. Dobutamine will increase cardiac output via its beta-1 effect and does decrease pulmonary vascular resistance, its beta-2 effect. So in patients who have pulmonary hypertension undergoing cardiac surgery, dobutamine has several beneficial effects, helping the right heart beat harder, left heart beat harder, and also decreasing pulmonary and systemic vascular resistance. So dobutamine, beta-1, and beta-2 agonism. Norepinephrine, unlike epinephrine, is intensely alpha-1 without beta-2. So epinephrine has beta-1, beta-2, and alpha-1, but norepinephrine will not have that beta-2 or vasodilating effect. So it's an intense vasoconstrictor via the alpha-1 and will enhance myocardial contractility via the beta-1. Norepinephrine is frequently used in patients who are massively vasodilated and hypotensive. And if we look at the graphic on the far right, you can see that alpha agonists bind to alpha-1 receptors, causing increase in cytosolic calcium and vasoconstriction. So in the patient who has septic shock, vasopressin is often added to norepinephrine. If norepinephrine is already infusing, vasopressin may be added to it, and those together often can increase the blood pressure, or the vasopressin added to the norepinephrine can result in utilization of a decreased dose of norepinephrine. But norepinephrine during septic shock is used for its alpha-1 effect and vasoconstriction. There is vasoplegic syndromes that can occur, for example, after cardiopulmonary bypass, in which patients are not responding to catecholamines, and vasopressin may be used instead of norepinephrine in those cases, but norepinephrine may be one of the first drugs to use. There are some problems with norepinephrine. It is a catecholamine that can cause arrhythmias. It's thought to be less than epinephrine, though. It can increase pulmonary vascular resistance. Alpha-1 receptor agonism can constrict blood vessels. The pulmonary vasculature can be constricted when norepinephrine is started, and the RV may not like that, pumping against a higher resistance. So think about norepinephrine administration to a patient who has high pulmonary artery blood pressures and an RV that's not functioning so well. There are probably better choices. Also, norepinephrine is an intense constrictor of renal and splanchnic blood flow, reducing both. So in summary, norepinephrine, mainly used for its alpha-1 vasoconstricting effect, but also has a beta-1 effect and can increase contractility and heart rate. Isoproterenol, not used very much anymore, but has beta-1 and beta-2 effects, and you can compare that to dobutamine, which also had beta-1 and beta-2 effects. Isoproterenol, via its beta-1 effect, is going to cause increased chronotropy, and increased contractility and vasodilation via its beta-2 effect. Historically, this was one of the drugs reached for in patients after cardiac transplantation who were denervated in an attempt to activate the beta receptor and increase heart rate, i.e. a pharmacologic mode of pacing. Transvenous or epicardial pacing has replaced that, and epinephrine is the drug of choice in a patient post-cardiac transplantation who is both bradycardic and hypotensive. In a patient who has RV failure with pulmonary hypertension, isoproterenol had been used in the past because of its beta-2 effect in decreasing pulmonary vascular resistance. However, this is historically because we have much better drugs now to help the RV beat better and to decrease the pulmonary vascular resistance. There are some problems with isoproterenol. One, it can cause myocardial ischemia. Why? Because heart rate goes up via beta-1. It's vasodilating, so it's decreasing diastolic blood pressure, which is part of the coronary perfusion pressure. It's reducing coronary perfusion pressure, and it's making the heart work stronger, so it's using more oxygen. It's contracting more. So all those things together make the heart use more oxygen and can precipitate myocardial ischemia. Occasionally, isoproterenol is used in the electrophysiologic study lab where infusions can help delineate certain pathways or ectopic foci of dysrhythmias as they're being mapped. That may be one of the few uses still of isoproterenol. Now, dopamine has effects at dopaminergic, beta-adrenergic, and alpha-adrenergic receptors. It's an agonist at dopamine 1 receptors, and most books will say in low dose and in medium dose at the beta 1 receptor, and at high dose the alpha 1 receptor. However, there's lots of crossover here, and it's not uncommon to see beta 1 effects at relatively low doses of dopamine, that is, increased heart rate and contractility. The D1 receptor, when it's activated, results in diuresis and natriuresis, or loss of water and sodium, and it increases renal blood flow and glomerulofiltration rate, as well as sodium excretion. And it vasodilates the mesentery, as well as the renal artery. In the past, renal dose dopamine was used in an attempt to improve renal failure outcomes in both surgery and in an intensive care unit. The most current evidence suggests that it does not improve renal failure outcomes. Some side effects of dopamine include dysrhythmias, tachycardia, even as I mentioned before, at low doses, such as D1 low dose, where you're, quote, attempting to increase renal blood flow, and it may worsen myocardial ischemia. Let's look at some sympathomimetics next. Ephedrine is a commonly used medication in the operating room when a patient is hypotensive and bradycardic. Ephedrine has both an indirect and a direct effect. Its indirect effect is to cause presynaptic release of norepinephrine. Remember that norepinephrine has both alpha and beta 1 effects. Its direct effect is on the receptors alpha and beta themselves, causing an agonistic effect. So if it's agonistic at the alpha and beta receptor by an indirect and direct mechanism, it's going to result in increased heart rate via beta 1, cardiac output, and systemic vascular resistance will go up because of alpha agonism. It's not uncommon to see tachyphylaxis with ephedrine. That is, if you give 5 milligrams and it works for a while, the next dose has to be 10 milligrams, the next dose has to be 20 milligrams to get the same effect, especially in post-spinal hypotension, in obstetrics, C-section, for example. Occasionally you'll see the tachyphylaxis with repetitive doses of ephedrine. We use ephedrine often along with phenylephrine as the two most common drugs in the operating room to treat hypotension. But if you have a low blood pressure and a low heart rate, ephedrine is especially beneficial. Some problems with ephedrine is that in patients, for example, who are taking MAOI inhibitors, which increase presynaptic norepinephrine, remember ephedrine has an indirect effect, and you got all this norepinephrine sitting presynaptically, and you can have a very unpredictable or massive effect from ephedrine than usual. Pheochromocytoma is another area where you would want to avoid the indirect action of ephedrine and move right to direct-acting medications. Phenylephrine is a direct-acting alpha-1 agonist that causes vaso and venoconstriction. In fact, increasing preload is probably one of the major mechanisms of its increasing blood pressure. But it does also increase afterload. Blood pressure will go up after phenylephrine is administered, and you'll usually see a reflex decrease in heart rate as the blood pressure increases. It's constricting the capacitance vessels as well as the splanchnic, renal, and skeletal muscles, and as those capacitance vessels constrict, preload goes up to the heart, and as the heart fills, it contracts more. So both a preload effect and an afterload effect from phenylephrine via the alpha-1 receptor. Some problems with it is if you give phenylephrine to a patient whose cardiac function is not very good, let's set up an example of an EF of 15%, their blood pressure's down, and you give phenylephrine, which raises afterload and preload, that heart may not like it, and cardiac output may actually go down, and phenylephrine can also vasoconstrict the pulmonary vascular resistance. Milrinone is the next medication that we will look at. It is an inodilator. We'll first look up at the top right graphic and show that PDE3 inhibition results in reduced breakdown of cyclic AMP. If there's more cyclic AMP in the cell, there's more calcium and more contraction. So one mechanism of its effect, inotropy, is PDE3 inhibition, reducing cyclic AMP breakdown. Interestingly, it also, via that mechanism, causes increased relaxation. There's energy to cause cardiac muscle relaxation, lusitropy, or diastolic function we often think of. PDE5, if we inhibit that, you can see in the graphic on the bottom, PDE5 inhibition increases cyclic GMP, and in the systemic vasculature and the pulmonary vasculature results in vasodilation. So, inotropy via PDE3, vasodilation via PDE5, and in fact, if you give a rapid bolus of milrinone, typical dose 50 mics per kilogram, one of the first things that you'll see is vasodilation and hypotension. It is not the initial drug of choice for a patient with both LV, RV failure who has hypotension also, because if you bolus the milrinone, yes, it's an inotrope to both the LV and RV, but you'll see the vasodilation and worsen the hypotension. Frequently, milrinone is administered to patients who have RV failure and pulmonary hypertension to increase RV inotropy and to decrease pulmonary pressures, remembering again that if the patient is severely hypotensive, milrinone would not be the first drug to reach for. Epinephrine might be your first drug to reach for. When you're weaning from cardiopulmonary bypass, combining two medications, one a beta agonist such as epinephrine and a phosphodiesterase inhibitor, results in two mechanisms for increasing intracellular cyclic AMP, the beta receptor as well as reducing cyclic AMP breakdown by the phosphodiesterase enzyme, and you can get more inotropy as a result. The next drug that I'd like to talk about is vasopressin. And up at the top graphic shows arginine vasopressin being released. It's released from the posterior pituitary. We give it intravenously, and it attaches to the V1 receptor on vascular smooth muscle and increases systemic vascular resistance, and that's the main reason for using vasopressin, is its vasoconstrictive properties. It does that by activating the V1 receptor and increasing calcium intracellularly, contracting the vascular smooth muscle. Clinically, vasopressin is used to raise blood pressure in vasopressin deficient states. Examples of vasopressin deficient states including sepsis, cardiac arrest, vasodilatory shock, catecholamine refractory hypotension. Sepsis is a very common one where vasopressin is used. ACE and ARB, when they are administered in the perioperative period before surgery, occasionally can result in severe hypotension in the surgical time during anesthesia, and hypotension related to ACE, angiotensin converting enzymes, and angiotensin receptor blocker agents. The hypotension can be treated with vasopressin. Sometimes it's resistant to catecholamines. Post-cardiopulmonary bypass, all the inflammation and the things that go on during cardiopulmonary bypass can result in a vasoplegic-like state after bypass, where catecholamines like norepinephrine may not be vasoconstricting adequately. Vasopressin can be used, and methylene blue can be a last resort. During cardiac arrest, vasopressin may replace epinephrine for requisite vasoconstriction. 40 units are used. It has a longer half-life than epinephrine. Remember, epinephrine was administered every 3 to 5 minutes, while vasopressin is administered once. So that's the main difference between epinephrine and vasopressin during ACLS administration. It is contraindicated, that is vasopressin, with local anesthetic systemic toxicity. There seems to be less effect on the pulmonary vascular resistance than norepinephrine, i.e. if you need a vasoconstrictor and you're worried about your pulmonary vascular resistance, the patient has pulmonary hypertension, vasopressin would be a better choice than would be norepinephrine. And when a patient is acidotic, let's say their pH is down quite low and you need vasoconstriction, vasopressin may be more effective than catecholamines in this scenario. At the far right bottom, the graphic is simply showing during sepsis there is a lot of things going on with gram-negative bacilli, for example, with release of different factors from cells, and changes in nitric oxide metabolism. There may be increased nitric oxide, and that may be part of the reason why there is such massive vasodilation during sepsis, which can respond to vasopressin. Norepinephrine and vasopressin are the drugs often used to treat the vasodilation with sepsis. Let's move from vasoconstrictor, vasopressin, to vasodilators now. And the mechanism of these nitrovasodilators, which are nitroglycerin and nitroprusside, are shown at the top right. In this graphic, you can see sodium nitroprusside and organic nitrates resulting in increased nitric oxide, increased cyclic GMP, and relaxation of smooth muscle. And it does that by increasing calcium reuptake, so less calcium in that vascular smooth muscle. Nitroglycerin has a tendency to dilate venules more than arteries, so it will decrease preload. But it also decreases pulmonary vascular resistance. So a patient with pulmonary hypertension, a patient who you want to reduce the preload, nitroglycerin can do that. It will also decrease afterload to some extent. A patient who's having myocardial ischemia, nitroglycerin improves myocardial supply demand. It does that by, one, decreasing preload and stretch on the left ventricle, so left ventricular end diastolic volume, and it also dilates the epicardial coronary arteries, improving blood flow. One of the main mechanisms, though, is its decreasing in LVEDV. If a patient is hypovolemic and you reduce the preload even more, this would be not a good idea. So nitroglycerin administration to a patient who possibly is unrecognized hypovolemic can result in severe hypotension, as can combining sildenafil, which is used for erectile dysfunction, with nitroglycerin. You can get severe hypotension also. Tachyphylaxis, administering doses of nitroglycerin over long periods of time or in high doses can result in the requirement for increasing in higher doses. One of the byproducts of nitroglycerin is a metabolite nitrite, which can convert oxyhemoglobin, oxidize it to methemoglobin, and methemoglobin can be gotten rid of by treating a patient with methylene blue. Or in most cases, it can stop the drug and it will go away eventually. Nitrovasodilators too, let's focus on nitroprusside now. Remember that nitroglycerin was mainly a venodilator. Nitroprusside is mainly an arterial dilator. It has an extremely fast onset and offset, and therefore is very useful in hypertensive emergencies. A patient has a blood pressure of 250 over 150 and is having CNS changes, cerebral edema, for example. It also can be used to decrease afterload. An example of that would be if a patient had acute aortic insufficiency as you're medically managing them and possibly maybe even preparing them for surgery. If SVR goes up, the aortic insufficiency gets worse. If you dilate the systemic vasculature, the aortic insufficiency will get less. And so nitroprusside can be used to temporize and improve forward cardiac output, as it can with mitral regurgitation acutely and cardiac shock, by decreasing systemic vascular resistance. Some of the issues with nitroprusside include, as you vasodilate and drop their blood pressure, they will get reflexive tachycardic. And in fact, a young patient may get very tachycardic and keep their blood pressure up. And in those cases, combining nitroprusside with a beta blocker like esmolol can allow you to reduce the dose of nitroprusside overall and decrease that tachycardia. So esmolol combined with nitroprusside, you won't have to use as much nitroprusside to get the same hypotensive effect. Another issue with nitroprusside is that it increases physiologic dead space. Now, how does it do that? If it decreases blood pressure, including the pulmonary artery pressure, P little a, Remember, zone 1 of the lung is where P big A, alveolus, is greater than P little a, and so the more you decrease P little a, the more you're increasing zone 1 in the lung. And it also, that is nitroprusside, inhibits HPV. Hypoxic pulmonary vasoconstriction is a set point that the alveolus capillary unit has for how much blood goes past. And if you turn on a vasodilator, it changes that set point and maybe sends blood past alveolar units that don't have a high P big AO2 inside the alveolus, and overall your P little AO2 on your blood cast can decrease with vasodilators like nitroglycerin and nitroprusside. In patients with myocardial ischemia, nitroprusside is especially bad because it, 1, can cause coronary steal, 2, reflex tachycardia, increasing myocardial oxygen demands, and 3, decrease the diastolic blood pressure, reducing supply. Another problem with nitroprusside is a metabolite of this drug is cyanide, and cyanide can build up and cause toxicity. How do you diagnose that? If you have nitroprusside running at relatively high doses for long periods of time, but in high doses for short periods of time, it can result too. You can get cyanide toxicity, and it presents with tachyphylaxis, that is, you're having to increase the dose of nitroprusside to get the same hypotensive effect. Using high doses, you find on your blood gas that you're developing a metabolic lactic acidosis. And interestingly, if you had a mixed venous pulmonary artery catheter, you would find increasing mixed venous saturations. Well, why is that? That's because the cyanide is poisoning the tissue's use of oxygen, so it just goes around, the tissues don't use it, it comes back to the main pulmonary artery, and the mixed venous saturation goes up, i.e., let's say from a normal of approximately 65 to 70%, maybe up into the high 80s or 90% range. This graphic on the left is to show the metabolism of sodium nitroprusside, and you can see here that nitroprusside generates cyanide. Cyanide can be gotten rid of from the body several ways. 1, it can, in the liver, in the presence of hepatic rhodonase, a thiol or sulfur molecule can be added to the cyanide, or thiocyanate. And if you have good kidneys, you can excrete it. If you don't have good kidneys, it can build up and cause a toxicity in and of itself. That's the thiocyanate. Also, cyanide can bind to methemoglobin and form cyanomethemoglobin, and it becomes a real problem when it binds to cytochrome oxidases like cytochrome AA3 and inhibits oxidative transport and the inability to use oxygen at the tissue level, and concomitant acidosis. How do we treat cyanide toxicity? Give supplemental oxygen, yes. You can even put these patients in a hyperbaric chamber, which is a treatment for carbon monoxide poisoning also. But there's some drugs that we can give also. And a cyanide antidote package components include these. Amyl nitrate and sodium nitrate can be given to oxidize oxyhemoglobin to methemoglobin. And remember, methemoglobin then can bind with cyanide to form cyanomethemoglobin, which isn't a real problem. Sodium thiosulfate, administering that helps convert cyanide to thiocyanate. It's a sulfur donor and then is excreted renally. So amyl nitrate and sodium nitrate to oxidize iron from Fe+2 to Fe+3, methemoglobin, which then can bind cyanide or bind it with sulfur and excrete it. But give them lots of oxygen in the meantime. Hydralazine is a vasodilator that has direct vasodilating effects on arteries and arterioles. It's occasionally used in the recovery room, for example, in a patient who has postoperative hypotension. Their blood pressure is way up, but they're not tachycardic and they don't have coronary artery disease. Because hydralazine, when it vasodilates by reducing calcium in the vascular smooth muscle, there is decreased blood pressure and a reflex tachycardia. That will increase cardiac output, increase myocardial oxygen requirements, and myocardial ischemia is possible. So hydralazine as a vasodilator is used occasionally postoperatively in patients who have hypertension, assuming that they're not tachycardic or with coronary artery disease. Nicardipine is a calcium channel blocker and specific for vascular smooth muscle. Calcium channel being an L type. preferentially, when you give nicardipine, it will dilate arterial vessels. Remember, nitroglycerin was mainly venules, nitroprusside was mainly arteries. Nicardipine is an arterial vasodilator and will decrease blood pressure, but you're not going to get the same tachycardia that you do with nitroprusside. Remember, when you turned on nitroprusside, their blood pressure dropped. They would get reflexive tachycardia, even to the point where esmol may have to be added along with the nitroprusside. It's also a coronary vasodilator and does not have a substantial effect on the sinoatrial or atrioventricular nodes or cardiac contractility, as does diltiazem, which we use to block the AV node when you have atrial fibrillation with rapid ventricular response, or verapamil. So when do we use nicardipine? In the treatment of sustained perioperative hypertension as a calcium channel blocking agent, vasodilating agent, which can help us control blood pressure. Phenoldipam, not used very commonly, but is a selective D1 or dopamine 1 agonist. In fact, it's about 10-fold more potent than is dopamine at the D1 receptor. It doesn't have any significant D2 alpha or beta 2 effect, so it's not going to vasoconstrict via the alpha receptor. It's not going to work through the beta 2 receptor, which is vasodilation, but through the D1 receptor. Interestingly, it doesn't cross the blood-brain barrier also. And one of the major reasons phenoldipam was developed was to drop the blood pressure and to improve renal blood flow. Now, it causes renal vasodilation and does increase renal blood flow, glomerular filtration rate, and natriuresis or sodium excretion, and can be used for management of hypertension in the operating room. The specific patient who might benefit from this would be the patient who has renal insufficiency, who is also hypertensive, and you want to use a temporary intravenous agent to drop the blood pressure but want to maintain renal blood flow. Phenoldipam might be that drug. And in the past has been used during open abdominal aortic aneurysms with cross clamp, cardiopulmonary bypass, etc. But its renal protective effect has been questioned by many, but it's important to understand the pharmacology of this drug. Inhaled nitric oxide, instead of intravenously generating nitric oxide via some of the drugs that we give and the receptor agonism, we can also inhale nitric oxide into the alveolus, where, as the graphic shows in the top right, inhaled nitric oxide, often in the 20 to 40 parts per million range, goes into the alveolus, and then the capillaries going by generate nitric oxide and cyclic GMP and vascular smooth muscle relaxation, and the pulmonary vessels that go past the alveolus dilate. Now, if you're breathing it in both your lungs and all those vessels are exposed to nitric oxide, they will dilate and pulmonary vascular resistance will go down. So the patient with severe pulmonary hypertension and right heart failure, you can see how inhaled nitric oxide could be beneficial. Unload the right ventricle and decrease the pulmonary blood pressure. It has been used in patients with ARDS in an attempt to improve VQ matching. It is a very short half-life and does not vasodilate the systemic vasculature. Now, why doesn't it vasodilate the systemic vasculature, but it does to the pulmonary vasculature? Simplistically, the nitric oxide binds to hemoglobin and forms nitrosomethemoglobin. So methemoglobin is a problem potentially with chronic use of nitric oxide, but there's a lot of hemoglobin around that nitric oxide can bind to, and by the time it binds to it and gets through the pulmonary vasculature into the left atrium, through the left ventricle and out in the aorta, it is not active. It's bound to hemoglobin. So free nitric oxide vasodilates, bound nitric oxide to hemoglobin doesn't vasodilate, therefore the effect of inhaled nitric oxide is limited to the pulmonary vasculature. Other side effects of nitric oxide, other than methemoglobinemia, is immunosuppression, platelet adhesion and aggregation inhibition, and it's not usually wise to turn off nitric oxide from relatively high levels to totally off in a short period of time, because a rebound effect can occur. For example, if you're at 40 parts per million and shut it off, you could get an increased pulmonary vascular resistance, decreased PaO2 as a rebound effect. Let's talk about alpha blockers next. Drugs that are not used very frequently include phentolamine and phenoxybenzamine, except when you're discussing the treatment of pheochromocytoma. Pheochromocytoma, remember, often is a norepinephrine secreting tumor, and you want to block the alpha receptor, at least that's the usual recommendation, prior to someone coming to an operation for their pheochromocytoma. Phentolamine is a non-selective, competitive, and reversible alpha-1 receptor antagonist, while phenoxybenzamine is a selective, non-competitive, irreversible alpha-1 receptor blocker. So you got several choices here to block the alpha receptor. We use labetalol fairly frequently, and we think of it as a beta blocker, but remember also that it has alpha blocking effects, so it can slow the heart rate and vasodilate, decreasing the blood pressure. Interestingly, labetalol has little effect on cerebral blood flow and intracranial pressure when you're giving it to patients who are hypertensive and, let's say, have increased intracranial pressure. For example, if someone had an ICP of, let's say, 25 and their blood pressure is way up and you wanted to decrease their blood pressure, nitroglycerin and nitroprusside would not be great choices because they are cerebral vasodilators and an increased cerebral blood volume, while labetalol does not tend to do that. Neither does esmolol. Labetalol also has little effect on the hypoxic pulmonary vascular response, again, unlike nitroglycerin and nitroprusside, which are inhibitors of HPV and can decrease the P-LaLeo2. Don't get confused with clonidine. Remember, clonidine and dexmedetomidine are alpha-2 agonists, not antagonists. And when the clonidine is administered, its alpha-2 agonist effect results in decreased presynaptic norepinephrine release. It's not an alpha blocker. Let's move to angiotensin converting enzyme inhibitors and angiotensin receptor blockers next. The graphic at the far left shows angiotensinogen protein worked on by renin from the kidney, forming angiotensin 1, and then angiotensin 1 being converted to angiotensin 2 by ACE, or angiotensin converting enzyme, present in the lung. Angiotensin 2 results in vasoconstriction, aldosterone secretion, sodium reabsorption, water reabsorption, and hypertension. On the right here, you can see bradykinins are broken down by angiotensin converting enzyme. And so by inhibiting ACE, you reduce angiotensin 2, but you also reduce the breakdown of bradykinins, which are part of the reason why ACE inhibitors result in hypotension, the buildup of bradykinin. It's also the reason, and the graphic shows it to the far right, that when you give an ACE inhibitor and you don't break down bradykinin can result in one of the side effects of ACE inhibitors, which is a cough. Now, ACE inhibitors are frequently held before surgery because of the worries about hypotension. When you have hypotension in a patient on an ACE inhibitor, sometimes it can be catecholamine resistant, and vasopressin may be especially helpful to cause vasoconstriction in this instant. Cough and angioedema are a side effect of ACE inhibitors. Notice that ARBs get past that bradykinin issue, but there are contraindications to ACE inhibitors, including renal artery stenosis. ACE inhibitors will reduce renal blood flow and can cause renal failure, and a history of angioedema, swelling up with previous ACE treatment. And by the way, the orange here represents the keywords and key topics that have been present between 2010 and 2016 on the ABA-IT published keywords. Let's talk about beta blockers and finish up here shortly. Beta-1 selective beta blockers include esmolol and metoprolol. We usually use beta blockers for their anti-ischemic effect. That is, they reduce myocardial oxygen demand by decreasing contractility, and they increase myocardial oxygen supply by slowing the heart rate, giving more time on diastole, and improving coronary blood flow. Esmol, like metoprolol, are selective in that they're selective for the beta-1 receptor. It has a short half-life, however, because it's hydrolyzed by red blood cell esterases with a half-life of only 9 minutes, which makes it a great titratable beta blocker. As opposed to metoprolol, which is also cardioselective beta-1 blocker, but has a longer half-life measured in hours. There's some new recommendations about beta blockers in the perioperative period, and in orange here represents the take-home message. That is, if we are going to give beta blockers to beta blocker naive patients, those that are not on it, and they come to an operation and we start them on beta blockers, there's been an association with decreasing the risk of non-fatal MI, but actually increasing the risk of stroke and mortality. So think twice before starting a beta blocker on someone who's not already on it when they come to surgery, when you're attempting to reduce the perioperative incidence of myocardial ischemia and myocardial infarction. Also, if someone is on a beta blocker and comes for a surgery, abrupt withdrawal of those is harmful, and beta blockers should be continued in those patients undergoing surgery who have been on beta blockers. So that's the take-home message about perioperative period and beta blockers. Let's change gears for a moment to amiodarone, which was a common keyword. Amiodarone is used to treat both ventricular and supraventricular dysrhythmias. Supraventricular dysrhythmias including Wolff-Parkinson-White. So it's kind of a be-all, end-all antidysrhythmic because it covers pretty much everything, except torsades is something we're going to talk about next, where amiodarone can actually make things worse. Now, the dose of amiodarone in a patient who has persistent VTAC, VFib that's been resistant to defibrillation, you've shocked them and they're not coming back, 300 milligrams IV is the dose. If they have a perfusing rhythm, the dose is lower, 150 milligrams over 10 minutes, repeated as necessary, remembering that as you bolus amiodarone rapidly, it can cause vasodilation and negative inotropy. It also prolongs the QT interval, and therefore in patients with torsades, which is our next topic, amiodarone would not be indicated. There's some side effects of amiodarone, mostly with long-term use. One is pulmonary fibrosis. Another is little corneal microdeposits. And another one is because it contains iodine, it can mess up the thyroid, causing both hyper or hypothyroidism. And torsades is the last topic, or polymorphic VTAC. Polymorphic because it has many forms. You look at the graphic up top, that's definitely not monomorphic, each one looking the same, but polymorphic. And in patients with prolonged QT interval, they're especially at risk for this dysrhythmia. Many of our antiemetic drugs, such as droperidol, 5-HT3 inhibitors like ondansetron, tricyclic antidepressants, and phenothiazines can prolong the QT interval. It's especially associated with hypomagnesemia. In a patient who has torsades that comes and goes, make sure that you correct their magnesium. If it's unstable, you're going to defibrillate them. If it's stable and you have time, you're going to give them magnesium, and you're going to attempt to increase their heart rate to decrease their QT interval. And remember that drugs like lidocaine and procainamide and amiodarone, that may be drugs that we use to treat ventricular tachycardia, would not be great drugs in this situation because of the QT interval prolongation. So let's look back at our ABA keywords 2010 to 2016 and see what we learned. Inotropes, bradycardia, and heart transplant. Remember, the beta receptors are still present on a transplanted denervated heart, and they will respond to beta agonism. Drugs like epinephrine, if the patient is bradycardic and hypotensive. Dobutamine can be used, Isoproterenol can be used, but epinephrine if they're hypotensive also. Norepinephrine is going to cause vasoconstriction mainly through the alpha receptor. Digitoxin toxicity because of its sodium-potassium ATPase inhibition. It is especially worsened by hypokalemia, and you're going to correct the potassium. Milrinone is an inodilator via its phosphodiesterase type 3 inotropy, phosphodiesterase type 5 inhibition, and vasodilation. It is increases inotropy of the heart, and vasodilates both the systemic and pulmonary vasculature, and is great for patients with right heart failure and pulmonary hypertension. But remember that bolus milrinone is going to drop the blood pressure dramatically, and so in a hypotensive patient who's not doing well, bolusing milrinone not a great choice. Vasopressors, specifically vasopressin, acts via the V1 receptor, seems to work a little better than catecholamines in acidosis. And in septic shock and other states where vasopressin is already low is a good drug. And septic shock, norepinephrine is another one that is used to treat low vascular resistance. Vasodilators like Nitroprusside can get us into trouble because cyanide is a breakdown product, and we may need to use things like oxidizers of hemoglobin to methemoglobin and sulfur donors and oxygen to treat nitroprusside toxicity, which presents with tachyphylaxis, acidosis, high mixed venous, etc. Fidolizepam, we said, was a D1 agonist, increasing renal blood flow. And nitric oxide hemodynamic effect is to decrease the pulmonary vascular resistance without an effect on the systemic vascular resistance. And toxicity was methemoglobinemia. ACE and ARBs inhibitors, how they work, they reduce angiotensin II and also reduce the breakdown of bradykinin, two mechanisms for its hypotensive effects. Contraindications include angioedema history as well as renal artery stenosis. And one of the side effects of ACE is cough because of probably the buildup of the bradykinins, which does not occur with the ARBs, the receptor blockers. We talked about beta blockers and how in the perioperative period, if someone's on it, we should continue, and if they're not on it, we need to think twice about starting one because of the POISE trial. Labetalol, both beta 1 as well as alpha blocking effect. Beta 1 blocker, alpha 1 blocker, so decreases contractility, heart rate, and vasodilates. And specifically, we pointed out that it didn't have some of those negative effects on cerebral blood flow and hypoxic pulmonary vasoconstriction that nitroprusside and nitroglycerin did. Torsades is a weird rhythm, polymorphic ventricular tachycardia, where the treatment is magnesium and increasing the heart rate, and if they're unstable, defibrillating, but it's not one of those rhythms that we reach for, that be-all end-all antidysrhythmic amiodarone, which can be used for both supraventricular and ventricular dysrhythmias, but it causes vasodilation and negative inotropy when bolused. Although not mentioned in this lecture, the PGE1 use in congenital heart disease is mainly used and infused to keep the ductus open in patients who are ductal dependent. So it keeps the ductus arteriosus open. Indocin is an inhibitor, chemically will close the ductus in these neonates quite often. This ends our ABA keyword review on pharmacology cardiac topics, and I hope you have a great day. Don't ever stop learning. This is a picture of biking in Maine just this last month. Hope you have a good one.